Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with really impacted earwax in both ears. We're just commencing with their left ear. In actual fact, it was the right ear that was the worst one, but I decided to show you the left one first, just as a little taster. The right one, there was a lot of hairs in there, whereas this ear, although you can see there's a few hairs here, there weren't as many. I decided to show you this one first, as I know sometimes the hairs can get in the way of the view when you're watching it, so I thought you'll appreciate the left side more than the right for that reason. And as you can see, I'm just tugging away at this wax. It's really dry. There's a lot of keratin buildup as well, a lot of dead skin. And you can see it's been there for a while. It's really oxidized. It's almost pitch black. When it's dry like this, as you can see, it can be difficult to get a suction grip. And there's little tricks that you can implement. One of them being is using some olive oil spray, which I've already done actually. And what the olive oil sprays, it's medical grade. That's really important. So try not to use home olive oil. And the reason for that, even if you use really expensive home cooking oil, so extra virgin olive oil, that refinement process involves the use of chemicals, whereas medical grade oil, it's separated without the use of any chemicals, therefore it's safer to use. It's just, you always run the risk if you use home olive oil to develop an infection. It's probably not a very likely occurrence, but nonetheless, we always recommend medical grade. And I think I'm going to use a hook now. And I've managed to get the hook superiorly to the roof. I've just rotated the hook and I'm now coming out. The patient has got quite a bendy ear canal. When you've got a bendy ear canal, it's a bit more difficult to use hooks and jobs and horns because they don't actually have a bend themselves. Although the hook didn't remove that wax, it did almost like a hammer and chisel. It broke it up into little pieces, and I'm now therefore going back with the suction probe. So this is the standard zone, the suction probe, and when we vacuum earwax out of the ear, we call that microsuction. It's just blocked my tube there, so I've just come out and blocked it. We're now working in the inner half of the ear canal. This is what we call more medially towards the eardrum. And you can probably see that little rocking motion I use just to bring this wax forward. Now, because this wax is really dry, the surface of this wax, you can compare it to sandpaper. And when you're therefore removing the wax, you're just going to be slightly cautious because if you rub up against the ear canal too much, it can be quite abrasive and the patient can sometimes feel it. This patient was fine. The olive oil helped to combat that because it provided a layer of lubrication. So now we're the last third, I would say. You can see this wax has got a lot of dead skin enveloping it, and that skin acts as double-sided sticky tape. Not only does it attach itself to the surface of the wax plug, but it also is still adhered to the ear canal wall. And what we're trying to do here is separate it from the ear canal wall. And that white sheet of skin, that's freshly dead skin, and it's just shedded. The longer the skin is in the ear and it's been dead for, the longer it's been dead, the darker it turns, it oxidizes. So again, this fresh low skin, it's only just recently died and it's undergoing the shedding process. And whilst it's just attached itself to the wax plug. So the core of this wax plug is probably made up of a lot of dead skin that was originally on the canal wall, and it's been pushed deeper and deeper into the core of the wax plug. Now, you may not be able to see it at the moment, but this patient has got quite a recessed, inferior recess. So as we approach the eardrum, the ear canal narrows and then it widens back out. And it widens inferiorly, so to the base of the ear canal, and then it also widens anteriorly, so to the front of the ear canal on the left-hand side, because this is the patient's left ear. And it creates a little trench, a little basin near the base of the eardrum, the bottom of the eardrum, and a little alcove to the front of the ear canal. And quite often wax and dead skin can get trapped in there, and that's what's happened in this case. So we're having to try to lift it out of that little basin, that little trench. I've decided to try some forceps because this wax is quite dry and you can get good purchase on it, but it's really strongly adhered, and although I'm pulling it, I can still feeling it itself attaching to the eardrum. So I've just put another squirt of oil in there. You can probably see that oil, it's just penetrated over the wax plug, and bit of it's on the eardrum. To the right you can see that blue tinge, and that's the eardrum revealing itself. And I've managed to lift it out of the inferior recess. I'm just trying to get a suction grip, again, because it's really dry. Sometimes you don't get a suction grip for that reason, and inadvertently you can push the wax plug further in if you're not getting a suction grip. So I'm going to just try the forceps again. I've widened the jaws, I've got around it, and I'm just pincing at it. There we are. And because it's quite a solid piece, it's as I'm closing up on the wax plug, it's somewhat pushing it further in. So I've just come back out. I'm going to just suction this. And see it's some at the top as well, on the roof of the ear canal. And I've got a suction grip here, and I'm just being really cautious, really coming out slowly. If I come away too slowly with the sucker, I'll lose that grip. There we are, I've got that plug out. So the eardrum is partially in view now. Once more, this wax is really dry, and there's a few hairs there matted against it. You can see the eardrum. Now the eardrum's intact. The hammer bone itself, it looks a bit slightly deformed. It looks a bit more broader than the norm, and that could just be individual difference in this particular patient, or it could be this patient does suffer from eustachian tube dysfunction. So the eustachian tube is a tube that connects the middle ear, which is a cavity behind the eardrum, to the back of the nose. And the function of the eustachian tube, it's an equalization tube. It helps to equalize the air pressure. Ideally, we want the air pressure behind the eardrum to be equal to the air pressure in front of the eardrum. So when the air pressure is equal either side of the eardrum, that's when our eardrum is most mobile, and therefore it's going to be transmitting more sounds through to the organ of hearing, the cochlea. Now, if that eustachian tube gets blocked, and it normally gets blocked at the back of the nose, the nasopharynx, there's then a vacuum of air. There's no air behind the eardrum, which creates negative middle ear pressure. And when you've got negative middle ear pressure, quite often your eardrum gets pulled inwards, a bit like when you're on a plane and you're descending. And this patient does suffer from chronic eustachian tube dysfunction, so their eardrum is normally, more often not, sucked inwards. And the eardrum can then wrap itself around the hammer bone really tightly, and sometimes it can constrict the blood vessels. Now, when it constricts the blood vessels, the hammer bone, or it could be also the incus, the middle bone, or sometimes even the stapes, they don't receive the required blood supply and all the nutrients in the blood, and it can cause some necrosis, some diseasing of the bones, some wearing away, some erosion. Now, you can probably saw there, you can see all the blood vessels there, so despite the eardrum being sucked in, the blood vessels are still visible. So I'm not sure if that's the root cause of this patient. So ear 2, so this is their worst ear. This is the one that they primarily came in for. It's a lot more hairy, as you can see. Now, the patient did use some drops. It wasn't drops that I'm very keen on. They use some hydrogen peroxide drops. And the reason why I'm not keen on it, hydrogen peroxide, it has its merits. It has its scientific foundation and basis. So when you instill hydrogen peroxide drops, what happens is it's water-based initially, and it therefore has a dual action. The water gets absorbed by the dead skin, and a lot of earwax is made up of dead skin, around 60%. So the skin cells, all the dead skin cells, all the exfoliated skin that forms the wax plug, absorbs the water in the hydrogen peroxide drops. It then swells and bursts, and that kind of fragments the wax plug. In addition, when you introduce hydrogen peroxide into the ear, it reacts with a certain enzyme within the ear, and it then causes the effervescence of oxygen. So oxygen is released, it's liberated, and it bubbles away, it foams away, and that mechanical foaming is also believed to help break up wax. So it doesn't dissolve wax, and I've probably said that a few times in my recent videos, because when I interpret the word dissolve, it implies that it disappears, but it doesn't make the wax disappear. It's still in the ear. but it breaks it up, and that's what's happened in this case. But when it breaks it up, it makes it really mushy. And when it becomes mushy, it's just a bit harder to remove, to vacuum, to suction, because it clogs up the suction probe. In addition, hydrogen peroxide, as I mentioned, is water-based. It's alkaline, so it increases the pH level of the ear. And if you increase the pH level of the ear too much, it then gives an opportunity for certain bacteria and fungi to reproduce and grow into the ear. Acts as almost like an incubator. It provides the perfect breeding grounds when you've got a slightly higher pH level. Water-based drops for me as well, and that's why it's a bit mushy, I suspect. It macerates the dead skin. It makes it really soft and mushy, and I don't really like that. Water can always lead to an infection. Hydrogen peroxide drops is a good antiseptic, so I think with any drops of excessive use, it can possibly lead to infection, but although it's an antiseptic, for me, again, when it macerates the skin, because not only is it going to macerate the skin that's exfoliated dead skin cells within the wax fluid, but it's going to also, if it can get contact with it, the surface skin of the ear canal, the epithelial layer, and it's going to macerate that, and it's going to soften that. And when you macerate that outer layer of skin, again, certain bacteria and fungi can then invade the deeper layers of skin, the dermis and the subcutaneous layer. So we're nearly there. We're up to the eardrum now. I'm just going to tease this away. You can see, as I mentioned before, there's a lot more hairs in this ear compared to the left ear. I'm just trying to gently wriggle this. So at the roof, the wax is really dry and crusted. At the base, it's really soft and mushy. And that could be because of the drops. When the patient put the drops in, it penetrated the floor of the ear canal more, as opposed to the roof of the ear canal. And it's just lodged, and I'm just rocking left to right. It's going to be, sometimes when you suction, and I was probably guilty of it, and probably still am sometimes, you get overzealous and you're trying to remove it too quickly, and when you do, you just lose the suction grip. So sometimes you just got to linger in there, hover over it, and let the suction do the job. So you can see the half the southern hemisphere of the eardrum. We're now going to remove this dry, crusted, dark, oxidized wax from the northern hemisphere. You can see all those hairs in there, so it's likely, I've given the patient some tips, but it's likely that when the patient trims their ear hairs, that these hairs fly into the ear and it mats against the wax, which makes it more difficult for the wax to naturally migrate on its own accord. So it's just attached to the roof, and I'm just trying to peel it away. We're on the bony, osseous part of the ear canal, so we're going to be really gentle here. It's a very sensitive part of the ear. And I managed to extract that. So it's just a bit of dead, crusted keratin. Just going to hover over this. And there was a tiniest speck of skin just near the hammer bone. I was going to leave that because in order to get that, I just run the risk of potentially making contact with the short process of the malleus. So the malleus is the hammer bone. You get the top, you can see this that spherical piece of the malleus bone, the very rounded bit. And that, we call that the lateral or short process. And if you just don't want to make contact with that, and I probably would be close to doing so if I try and remove that last piece of skin, but it's not problematic. There's the patient's eardrum. I'm just going to mop up near the entrance. In a moment, you're going to have a still image of all the wax and dry skin that I removed from both ears. So I laid it out on the tissue. There we are. So that's the content from both ears. You can see all that white dead skin. That's the fresher layer of skin, and all that dark matter is oxidized, really aged, matured earwax and dead skin. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Thank you. Bye.